Another aspect of safety is the consent. But the consent emphasizes that the screening is done in part just to make sure that the study is safe for the participant. We've tried to avoid words like eligibility, but they're still in there, you know, given that it's kind of a higher language level, as you might call it. But if you can remember when you're talking with participants that one of the purposes of screening is really to make sure that the study is safe for her. And the consent discusses possible risks, and so it sort of flat out says what are some of the symptoms and adverse effects associated with escitalopram, including the fact that there are sometimes new symptoms that come up when the medication is withdrawn, and it's one of the reasons why we're tapering for participants who are taking 2 study pills towards the end. It also discusses the possibility of suicidal risk, and it discusses the need to avoid pregnancy. And so that's right there in the consent, but it's repeated in the handbook, and I'm hoping you will also, as you go through the consent process with your participants, kind of highlight some of those safety concerns. Alerts are then done, so you might be alerted to a value when you're doing measurements during screening or follow-up, and so these are things that don't necessarily exclude the participant, but they might, during follow-up, require discontinuing study pills, or they might warrant care. So for heart rate, if her heart rate is 110 over 119, remember 120 means she's excluded, but you should tell her that her heart rate is high and recommend that she make an appointment with a primary care physician. If it's 120 to 129, and regular, again, it's not a reason to discontinue study pills, but you want to refer her to a clinician to evaluate whether study pills should be discontinued on a case-by-case basis, and recommend immediate contact with their primary care provider. And if the heart rate is over 130 during follow-up, the requirement is to discontinue study pills and make an immediate phone call to their primary care provider. Any questions about that? Yeah.
So is this for all the protocols or just this particular?
Currently, it's just this particular protocol. I really hesitate to, even though it's somewhat thought to be a general alert, you know, things may change, including just what we learn in medical science as the study rolls along. Yeah.
Barb, the immediate call to the primary care provider if the heart rate is over 130, is that done by the clinic staff or by that's advice given to the participant to make a call immediately?
My recommendation would be that the participant make the call at the clinic, but if the participant doesn't want to, then the staff should. And it's sort of, you know, a conversation with the participant.
With the participant having the right to say no ultimately?
I don't think we've ever had that problem.
No.
They're pretty anxious to get appropriately cared for. Yeah, Julie?
So in the protocol, it says that it's immediate referral to the primary care via telephone. So I'm assuming that means the staff would make it.
Well, yeah, and as I said, it may be that the participant refers to make it, but it would need to happen at the clinic with the staff if they're seeing that it's happening.
Right.
Would that require a release signed by the patient to contact the PCP?
I wouldn't, you know, we don't have a protocol, but I wouldn't necessarily think so if they're sitting right there, because you're just calling them to say, this has happened, and we would recommend that you see the participant right away.
Some IRBs require that release. And for the patient,
Some IRBs do.
Yeah, at consent actually choose whether to notify the PCPs or not that they're even participating in the trial.
We haven't always required such a release for those kinds of referrals, but it just depends. The other thing I wanted to mention then, so I'm going to go over this with blood pressure as well. If the rate is 140 to 179 systolic over 90 to 109, again, you would tell her that her blood pressure is high. You'd recommend that she make an appointment with the primary care provider. And then if you when you do another check in 4 weeks, which would be either the 4-week assessment or the 8-week assessment, if it's still high, then that does require primary care referral. And that's been a recommendation from our Data and Safety Monitoring Board. If the blood pressure is 180 to 199 or 110 to 119 diastolic, they should be evaluated again by a clinician whether study pills should be discontinued, and you would recommend to the participant immediate primary care contact to schedule an appointment. And similar to the higher level for the heart rate, if the blood pressure is greater than 200 over 120, you would discontinue study pills and ensure that an immediate phone call to a primary care provider is made. Questions about that? So I mentioned a little bit about the study pill informational handout, and I'm here to say I'm calling a contest. If any of you can think of a really cool name for the handout, I'm open to ideas. You know, we try to make it a very friendly, warm thing with, you know, flowery pictures and things on it and whatnot, but I still haven't been able to figure out a cool name. So it's handed out at randomization, which is the first dispensation of study pills, and then you offer it at each subsequent dispensation. You don't need to force it on her if she says, I've already got it, but you would want to make sure that it's offered to her each time. And as I said, it's a friendly handout, it's informative, it's addressed to women whether they're taking active or placebo, and you want to really make sure that it's kind of not focused on one or the other, because you don't want the women to start getting, you know, the wrong idea that they're taking one or the other. I think our experience has been sometimes the women have information like that, and because it's filled with all of the potential symptoms and side effects, if you're taking the medication, then they start assuming they're taking the medication, and so you want to make sure that they know that they, you know, they're still potentially taking active or placebo. One of the reasons why we found in the WHI that this handout was helpful is that it really established a nice bond between the participant and the clinical staff. And I would recommend that when you first hand it to her, you actually kind of march her through it and point out the specific areas, such as information about the study, to remind her what the study's about, why they're blinded and why the staff are blinded, a discussion of the study pill regimen. Some other things include reminders about things that they're going to be asked to do in the study, like filling out the hot flash diary. Some suggestions about management of hot flashes that are permissible within the context of the study, and there's specific management strategies that they should not be incorporating into their hot flash management routine, so that it won't conflict with the intervention. Possible side effects, and for minor side effects, some suggestions about self-management strategies that they could try. Possible adverse effects and actions to take, which might be call your clinic immediately, call your primary care provider immediately, that sort of thing. And as I said, the cautions about pregnancy, not taking psychotropic medications, or contacting the clinic if the doctor prescribes those medications, and then specific clinic contact information if they have any additional questions. You know, based on feedback, we could put an FAQ, frequently asked questions, thing in there if that seems appropriate, but I think these sort of topics will kind of generally cover the gamut for such a short trial. It's probably not going to be the case where questions crop up that we'd have time to necessarily incorporate. Any questions about that or other suggestions as I'm working on that handbook? Would you find it helpful or annoying to have sort of some guidelines about how to march the participant through the handbook?
Guidelines are nice.
Okay. So I'll include in the sort of final manual draft some sort of talking points, so that it will guide you on things to point out and maybe some possible things you can say. So, oh yeah.